Hello friends, welcome back to Dr. Ashar Nadeem Awan ultrasound and radiology teaching videos. Hope you are all okay, you're all enjoying your life and you're also enjoying watching my videos. As you all know that these days I'm discussing about the musculoskeletal tumors, especially on the conventional radiograph and CT scan images. Today my topic of discussion is osteoblastoma. Osteoblastoma is a benign tumor and it's producing osteoid and woven bones. Histologically, it is similar to osteoid osteoma. In other words, it can be seen, it can be called as a big brother of the osteoid osteoma. The only difference is the size. It will be more than 1.5 to 2 centimeter. If it is more than 2 centimeter or 1.5 to 2 centimeter, it would be labeled as osteoblastoma. Otherwise, if it is reduced than that, so it will be called as an osteoid osteoma. Some other features are characteristics, like it has a bit aggressive behavior. The second thing, it does not resolve spontaneously. It usually involves the sacrums and the spinal cord, especially arches, and it has the capacity of to extension or producing soft tissues, extra osseous extension, which may result into painful scoliosis. Normally, the pain is a bit chronic but less severe as compared to osteoid osteoma, and it does not resolve with the aspirin intake. Mostly, it is a lytic lesion and it's more than 1.5 centimeter, usually seen in the spinal arches. This has the capacity of to expand the arch and to produce extra spinal features as well, which may lead to painful scoliosis. How it will appear on the CT scan images, how we will appreciate on the X-rays, how we will look for the differential diagnosis. All these are included in these subsequent slides. So let's start watching all these slides for the osteoblastoma. Osteoblastoma is a benign tumor and producing osteoid and woven bone. Histologically, it is similar to osteoid osteoma. In other words, it is also called as a big brother of the osteoid osteoma. The only difference between these two lesions are the size. The more than 1.5 to 2.0 centimeter or up to 2 centimeter would be considered as osteoblastoma, and any lesser than 1.5 centimeter would be considered as osteoid osteoma. It's tend to show more aggressive pattern and it does not resolve spontaneously. So far the osteoid osteoma is concerned, it is less aggressive compared to osteoblastoma, and the second thing is osteoid osteoma resolves spontaneously. So far osteoblastoma is concerned, it does not resolve spontaneously and it has much more aggressive pattern. So the radiological characteristic of both tumors are the same. The only difference depend upon the size. Clinical presentation of the osteoblastoma would be pain, and that would be usually chronic, as compared to osteoid osteoma. Osteoid osteoma pain will be very acute and it would be very severe, but osteoblastoma pain would be chronic and it would be less severe compared to osteoid osteoma. It will be rarely relieved by aspirin and can be painful. Scoliosis can cause painful scoliosis, and it is usually seen in less than 30 years of age, and it is capable of producing pain. The one important difference between the osteoid osteoma and osteoblastoma is that osteoid osteoma can be easily relieved by taking the aspirin, while this osteoblastoma won't. Osteoid osteoma can cause prostaglandin, that's why it would be relieved by the aspirin, but this is not the characteristic of the osteoblastoma. Osteoblastoma would cause pain, but it would be less severe, but it would be chronic and usually seen in less than 30 years of age, associated with painful scoliosis. So far its location is concerned, 40 to 50% are within the spine and especially the sacral area. 90% are eccentrically located within the neural arch with a painful scoliosis. There may be or may not be expansion, or there may be absence of the pedicles sometime. Potentially extra osseous extension is the characteristic of osteoblastoma, and other major sites are diaphysis or metaphysis of the long bone. But particularly when there is pain and the patient presenting with the pain and the age is less than 30 years of age, ranging from 10 to less than 30 years of age, and if there is a pain in the backbone, so always search for the neural arches, always look for the pedicles. Look here, an illustration shows osteoblastoma in the foot, and also there is a image of the scintigraphy which would always be positive. In the long bone you can also appreciate osteoblastoma that is bigger than the osteoid osteoma, and here on the right side you can appreciate that the transverse process of the lumbar vertebra is expanded with a particularly latex lesion, expansions of the cortex, it is intramedullary, and it also causes painful scoliosis. So this is the characteristic of osteoblastoma, and these are the sites for the osteoblastoma. X-ray finding, it is predominantly latex lesion and more than 2 centimeter. Larger lesion have a greater matrix mineralization. You can appreciate mineralizations and also expand the bone with surrounding sclerotic reactions. So this is quite easy to appreciate on the conventional radiograph because it happens to be a predominantly latex lesion. Here on this X-ray lumbosacral spine, you can appreciate that the left sided transverse process has been expanded due to well defined latex lesion causing expansion of the transverse process, and although there is no cortical breach, but on this particular X-ray you cannot appreciate mineralization, but in some cases there will be mineralization. So this is the example of osteoblastoma involving the left transverse process of the first lumbar vertebra, and it will appear on the conventional radiograph like that. So this is another example, and it is involving cervical vertebra, two transverse processes. It's causing as a ballooning, it is causing expansion of the transverse process. However, there is no cortical breach, there is no fracture seen on this given images. Centrally there can be seen a mineralization matrix. So this is what the characteristic of the osteoblastoma, and as I say, usually it involves the pedicles, it involves the transverse processes, and it involves the cervical and mainly the lumbothoracic vertebrae. On the CT images, the same it will appear on the CT as well, like it will be showing occult calcifications. There may be punctate calcification that may appear as a nodular. These calcification might appear as a generalized because of the matrix mineralization. So here you can appreciate one of the image. On the right side, transverse process is distended with a well defined hypodense lesion having a central calcific foci. So this is what the exact location of the osteoblastoma is, and it will appear on the CT images like that. Another image also shown here, you can also appreciate a well defined hypodense lesion with central mineralization. So this is the place for the this is a site for the osteoblastoma. Scintigraphy of the osteoblastoma will always be positive. It will always take tracer uptake, and you can easily appreciate this on the bone scan. Here is the example, and there is osteoblastoma sitting in the tibial region, and which is indicated by the black arrow. So it shows increased uptake. So scintigraphy will always be positive, and this would be another tool to confirm the presence of the osteoblastoma. X-ray will show particular images, while on the CT there will be particular characteristic, and on the scintigraphy you will see that there will be tracer uptake for the osteoblastoma. There are certain home take point which should be remembered. Osteoblastoma may produce an extra cortical mass causing spinal cord compression with a soft tissue component. Aggressive osteoblastoma would be locally aggressive lesion commonly seen in the sacrum, and it would be capable of producing metastasis. This is one of the important point, that it will cause extra cortical mass which may lead to painful scoliosis. Differential diagnosis for the osteoblastoma would be Brody's abscess, because Brody's abscess will also appear hypoequic. It will appear a lytic lesion on the X-rays, hypodense on the CT images, and it might be having calcification. So far the chondroid, chondromyxoid fibroma and Langerhans cell histiocytosis is concerned. These both shows the same characteristic, so that's why these both should be included in the differential diagnosis for the osteoblastoma. Yes, guys, this was all about the osteoblastoma. We have discussed at length this benign tumor. We have also discussed its characteristic, how it will cause a painful scoliosis, how it may be differentiated from the osteoid osteoma on the basis of the size, how it will expand the neural arches, how it will behave on the scintigraphy, and what will be the differential diagnosis. We have all discussed at length. So if any question related to these tumors you have in your mind, or any question, so just drop me a message, and I will get back to you with some other new information on the musculoskeletal tumor. We'll see each other in the next video. Till then, take great care of yourself. Bye bye.